Thank you all for coming. Thank you to be here after the lunch break. And I'm very happy to be here with you, and I want to thank B&B Dental family for inviting me as a speaker in this beautiful meeting. I'm very happy to be here in this beautiful museum, Lamborghini Museum. And today I want to talk to you about the split crest technique. And I want to start with a question. What we want when we have to do an aesthetic rehabilitation, an implant rehabilitation, what we are looking for when we start every surgical and prosthetic procedure. Isn't it to have, for example, a crown on an implant close to a natural tooth, and maybe a zirconia crown on a natural tooth? Isn't it what we're looking for? Is the restitutio ad integrum? Yes, it is. But what if we have to start from this situation where we have this concavity on the buccal aspect of the soft tissues, and we want to restore our crown on implant? When we look at the CBCT, we can see the reason why we have that aspect. We missed all the buccal aspect of the bone. And so what if we insert an implant and we have a crown and we leave the concavity that is going to end with a not really aesthetic prosthetic resolution? So hypothetically, how can we go from the left side to the right side? Of course, the right side is a Photoshop, but just to show what we need when we restore a single tooth, like in this clinical case. Since I started to do implant dentistry, my career is about 20 years, I do implant dentistry. I choose to avoid, when it's possible, to not do GBR or using biomaterials. And I wanted to use other techniques, like osteocondensation, split crest, using osteotomes, chisels, and screw-type expanders like this one that you can see in the picture. If you, like me, are interested in minimal invasive surgery and low morbidity and less appointments for our patient, just follow this lecture, because we will talk about what which are the biologic principles behind this technique. And I'm sure you will consider to use it in your daily practice. Of course, we have a learning curve in these manual techniques. We need to develop our hand feeling to listen to the bone, like Marco used yesterday. And this is very important, but I have to tell you that when we use the screw expanders, the technique is going to be easier and easier and predictable in the time. Then we talk about some tips and tricks about these techniques. We talk about how to use the expanders, how to design a flap, and how to suture in a daily practice. But let's go back to our topic. when the patient asks us for implant rehabilitation, they ask for the restituzio d'integro. They ask for a therapy that is at the same time a restoration that involves the bone and the tissue at the same time. From this article of Buser, is described like the aesthetic outcome and this long-term aesthetic stability is of paramount importance. This is the most important goal of implant therapy in this indication, of course followed by the proper function and phonetics. In this article, we can see that the 80% of the single implants that we treat every day is of this type 2 group. That is a group of clinical case where we have already lost the tooth and we are 4 to 8 weeks after the extraction and we have thin facial bone level, but still we have bone apically to insert the implant and to find primary stability. In my practice, actually, I do a lot of immediate implants and immediate loading, but still, in the 80% of the situation where we already lost the tooth, this is the situation that we deal with. So in this case, what do you do? We open the flap, a full thickness flap. We go for a GBR. We put biomaterials, and we use a membrane if we can. And this is from the article. Actually, is what we do schematically. We insert the implant, we graft the area, and we close with the primary closure flap. So let's think about the biology. How can we enhance the quality of the bone, avoiding the use of GBR or biomaterials? And we know that if we want to insert an implant in a thin crest like the one that we have here, if we use screw-type expander, bone expanders, we can avoiding the use of drills, so we are not going to generate heat to the bone. We are not removing with the irrigation the vital cells that we have inside of the bone, and also we will have a better visibility for the reason we are not using irrigation. And more, using the osteotomes or the screw-type condensers, we actually move the existing bone laterally and apically and enhancing the quality of the trabecular bone, because we enhance the resistance that we encounter when we then insert our implant in a new architecture of bone. We can see here in a short example, when we deal with the situation like the one that is described of Buser and the Crew article, what I do every day is to choose to make a very minimal flap with the papilla preservation and to evidence the crest, and start using the condenser, the compactor, with the stops to reach the length that we need for our implant. And even the implant, if it's designed in like this one is a 3P implant, even the implant makes a sort of osteocondensation. And at the same time, even if we don't put the healing abutment, we change the architecture of the white and the soft tissue, but still we can use the roll flap to enhance and move backly the soft tissue. So after few appointments, we deal with this kind of healing after 3 months, and then we can use this soft tissue to shape them with a provisional and go ahead with the final crown. So even in type 3, in type 4 bone, we can insert implant with one stage surgery and finalize the case in a very less invasive way. How can we change the architecture of both the bone and the soft tissues at the same time, like in this situation? Of course, when using the split crest, that is actually described in the literature as a technique that is a surgical procedure that allows us to split, to open the two corticals and separate them like a bone fracture, and to allow to the blood to form the clot and to form a new bone just between the two corticals that we have separated. We can, in this case, I used to utilize better some tools, like for example the piezo surgery, the beaver blade, or chisels to initially separate the two bone plates. Then I go forward with the screw type expanders. Actually, we don't need a lot of instruments to perform this kind of surgery. Here is the example of the instruments that I use for this case. We have the drills and the color code, so the analog expanders of the B&B Dental system, with one stop, that is the one that we decided for our implant, and that's it. Of course, I prefer to use the condenser, but sometimes we need still the drills, the burrs, to correct the direction of the implant, maybe if we want to go with the implant a little bit palatal, for example. And at the same time, we can insert the healing abutment and the roll flap to just in the first appointment to do all these mutations, or these changes to the architectural, to the soft tissues. It is important to underline that when I say a good primary stability, in the moment I decide to insert the healing abutment or to go through an immediate loading, it's important to understand that this connection of the B&B implants is a conical, a typical connection, and when we use the healing abutment, we need to go until the end, because you're gonna feel a first stop with the peak healing abutment, and you have to go further. And you go into the chronometry, and then you will feel the second stop. That is the stop that you have to reach when you use the healing abutment, peaky in this kind of implants. So with one surgery, after 3 months, we control the patient, and we can go forward to our finalization. This one actually is a temporary abutment and a new temporary, and it's just to show you the technique. One important thing that I use during these surgeries is also the partial thickness flap or the flapless approach. According to my opinion, this one is the best approach because we can maintain the periosteum, and that is very important when we split the ridge. We can fracture the bone wall. This is not going to be a big problem if we have still the periosteum on site. On the contrary, it's going to be a problem if we raise a full thickness flap. Here we see an example where I designed this minimal flap with half thickness width, and then started to use the condenser until we reach the last expander that allows us to insert our implant. And here, the system is very easy to use. Actually, this one is 3.5, so we use the red coded expander that is 3.3 of diameter, but still the implant is 3.5, so it's gonna make further osseo densification on site. That's the reason why I've used, like most of the cases actually, the healing abutment on the first surgery. And as you can see, the same approach for the roll flap allows us to find, after 3 months of healing, this kind of healthy tissues on which we can use the temporary, the provisional, to better shape the buccal aspect of our implant, and so we can go through the final prosthesis, where now we have convexity and non-concavity that we used to have at the beginning of the case, without doing any big surgeries, actually, with no biomaterials, with no membranes, and biologically speaking, without using any kind of drills and not generating any kind of heat to the bone. I want to show you how I deal with the roll flap in everyday practice. Same situation. They are all like this. If you don't do socket preservation, socket shield, or other procedures, to me, in my office, a lot of patients come with this situation, and we have to deal with this situation. So, usually the technique is with an incision that is not mid-crestal, but is a little bit palatal. Then, same protocol, we used the series, the color code expanders, until the stop. So it's very easy to use. And after that, I do this kind of suture. Actually, here we see where we enter, I tell you, but we'll see later. I enter palatal, and then I do kind of apically repositioned suture. So we tighten the mesial knot, and here you can see better how the the suture is done is you enter from here, from the external aspect of the palate, and then you take the flap like you want to apically reposition the flap. And this is the aspect when you just knot the two sutures. And just after the surgery, without any CTG and without any big reconstruction, we change the aspect of the implant. How we make this? I hope you will find the message I want to give you is that what we just saw is actually easy with a little bit of learning curve, because actually the biology helps us to well heal the wound. What I like best, other than the connection and then the implant shapes, morphologies, is the surgical kit of B&B Dental, because in one kit, actually we have all we need to perform this kind of procedures. We have the conical drills and the compactors and the stopper that we can use with both the conical and the compactors. It depends on what we need during the surgery. The universal racket and the straight manual key, we can use them with the implant drivers, but still we can use them with the compactors. So we can use the strike manual key and the compactors on the upper jaw, and the universal racket if we want to condense or split a crest in the lower jaw. And everything is well organized in only one kit with color code. Everything is well distributed, and the most important thing is that we need only that kit to perform this kind of procedures, not except if we need chisels or piezo or osteotomes. So, but here we have everything. So let's go back to the initial case where we saw the Photoshop, and in this case we decided to perform a flapless approach, and I didn't use even a tissue punch because I wanted to keep all the soft tissues and the structures of the patient. So I went through the normal protocol. This one is already the third expander. Actually, I went through the 2.2, then the 2.8, the 3.3, and the last one that is 3.8, so to insert a 4.0 implant. As you can see in these images, just using the condenser, not removing any kind of KT, we already moved bone and tissues buccally. So in the next, what actually we did, we went better. We were planning to insert the 3.5 by 10, but actually we were able to insert a 4.0 by 10 millimeters implant with this technique. And more, doing the one-stage surgery, the healing abutment also helped us to move more the tissues buccally, and so we could go through the impression, the metal try-in, And this is when, at the time, when we deliver to the patient the final abutment. It's already a good aspect of a healthy tissue on the buccally, but with the provisional we can improve the shape and the aesthetic of this implant, and so we can insert the provisional, the temporary, to move and to shape the tissue in a better way. After 6-8 weeks, the tissues are stable. So this is the image, the aspect of the tissues around the implant, and this allows us to go through the final prosthesis, the final crown, the control of the occlusion, and actually this is what we reach, is the famous crown on implant, natural tooth, and crown on the natural tooth, all together, trying to go the closest possible to the restitutio ad integrum that we reach when we start the rehabilitation. Of course, we have the X-rays. This is the post-op X-rays with the mesial and distal bone peaks. The 3 months X-rays, thanks to the connection and the insertion and the biology that loves this kind of techniques, we maintain the bone peaks in the time. And this one is the panoramic after 6 months, the 6 months after the delivery, where we can see that the bone peaks are still there because the conometry is, to me, the best connection we can have on an implant. So finally, with this technique, we can easily, with low morbidity, with less chair appointments for the patient, less surgery, less appointment after surgery for our patients, we can pass from this situation to this situation in an easy way. I want to thank you to stay here after lunch, and I want to give you just one slide, the last one. If you scan this QR code, you can take with you at home all the PDF with all the literature reference that we have of around this technique. Thank you very much. Te lo lascio qui. Te lo lascio qui.
Questo sì, lascialo qua. Allora,
Grazie.